Good afternoon, everyone. I am Rahul Gosain.
And I am Rohit Gosain.
And we are Oncology Brothers. Today, we're joined by Dr. Sara Tolaney, who's a world-renowned medical oncologist and division chief of breast cancer at the Dana-Farber Cancer Institute. In our discussion with her, we're hoping to focus on 3 clinically relevant studies that were presented at ASCO and how these studies should change your practice. Let's welcome Dr. Sara Tolaney.
Thank you so much for having me.
Thank you, Dr. Tolaney. For our discussion today, Dr. Tolaney, we are starting off with an update of Paloma 2 study, looking at the use of palbociclib in metastatic hormone-positive breast cancer patients. Can you please walk us through the study findings and how, if you've changed your practice based on this?
Yeah, no, this was, I think, data that we were all very eagerly awaiting, because while we knew that adding a CDK4/6 inhibitor to endocrine therapy in the upfront metastatic setting really doubled progression-free survival, what we've been wanting to know is, do these agents truly improve overall survival? So are patients actually living longer with this improvement in PFS? And so I think everybody's been really awaiting these data from Paloma 2, because this trial looked at patients in the upfront metastatic hormone receptor positive setting and randomized them to get an aromatase inhibitor, in this case letrozole, with or without palbociclib. And again, we'd previously already seen the PFS data, very robust, doubled PFS. The study met its primary endpoint, but we were waiting on this overall survival data. And remember, this was actually the very first of the CDK4/6 inhibitor randomized trials to be conducted in the upfront setting. And so again, this was very anticipated data, because most of us in truth had been using palbociclib in most of our patients since it was the first CDK4/6 inhibitor to market. And this trial, again, reported on the overall survival outcome and in fact did not show an overall survival benefit. I think there are some caveats, though, with this data that we have to keep in mind. One, because it was one of the very first trials to be conducted, during the course of this trial, the drug became FDA approved. And so there were patients who chose to withdraw consent to the trial upon approval because they wanted definitive access to the drug. And so this created a problem with survival follow-up in this trial, because there were many patients who withdrew consent and did not have follow-up for survival. And so this creates some imbalances between the two arms. And in fact, they showed a very interesting analysis where they looked at the subgroups and found that the subgroups that had a trend towards survival benefit were all in the subgroups where the arms were balanced for survival follow-up, whereas if the arms were imbalanced for survival follow-up, there was no trend towards advantage with palbociclib. So it does call into question if part of this result may be an issue with adequate follow-up in a balanced way across the two arms. So I think there are some challenges. There's also some differences in patient population compared to what's available with ribociclib, where this trial did allow more patients who had short disease-free interval onto the trial, which again could cause some differences in patient population. So we can't really do cross-trial comparisons. We can't say palbociclib's not as good as ribociclib, for example. But I think it is making us question if there are differences between the 3 CDK4/6 inhibitors, because clearly ribociclib's met OS in MONALEESA-2, MONALEESA-3, MONALEESA-7, and we've seen abemaciclib meet OS in MONARCH 2, and we've also seen benefits for abemaciclib in the adjuvant setting, where we haven't seen benefit for palbociclib in the adjuvant setting. And so it's making us wonder if there's some differences between these drugs. And so I think in terms of clinical practice, it then begs the question, what are you going to prescribe to your patient when you're starting them on a CDK4/6 inhibitor? And I'll be honest, I don't know that there's a right answer here. We still don't have survival data yet from MONARCH 3, so we don't know survival data yet with abemaciclib. So I think that will be very important data to see. But I think for the time being, if one was making a very data-driven decision, you would say, well, we only have survival data with ribociclib currently that's positive. And so I think there are many physicians who are going to choose prescribing ribociclib because it's the only agent in the first-line setting technically right now that has OS benefit that we know about. But for the time being, I do think many people are going to turn to prescribing ribociclib.
Well, thank you so much for that input. And as you said, the first one being palbociclib, and everyone got used to it, and same thing in community as well. Now, patients who are actually on palbociclib, would you recommend to change them to another CDK4/6 if they're tolerating well?
No, I think certainly one major advantage of palbociclib, it is very well tolerated, and it clearly is doubling progression-free survival. This agent is a very active drug. And if someone's benefiting from the drug, I would never change their therapy. Again, they're tolerating it. It's working for them. I wouldn't mess with it. I'd only think about, I think this really only should be an issue when you're prescribing a new drug for starting someone in the first line setting. And again, I don't think there's a wrong or right answer here. I think we just don't have all the data. We don't have the abemaciclib data yet. And there are some challenges with the Paloma 2 data. So again, not a wrong or right, but I think technically the only data we have with true OS advantages with ribociclib.
Okay, thank you.
Thank you for sharing that, Dr. Tolaney. Keeping the theme of metastatic hormone-positive breast cancer, we can now jump on our second study, Tropics 2, which was presented by Dr. Rugo. Here we're looking at sacituzumab in these patients. We know that sacituzumab is approved for metastatic triple-negative breast cancer. We also use it in bladder cancer. Can you please walk us through this study and its findings?
Yeah, so this was a really interesting study. The Tropics 2 study was conducted where patients who were, in fact, actually very heavily pretreated metastatic hormone receptor positive breast cancer were eligible. So you had to have progressed on a prior CDK4/6 inhibitor, and you had to have had between 2 to 4 prior lines of chemotherapy in the metastatic setting to be eligible for this study. So again, very heavily pretreated group of patients. In fact, patients had had a median of 3 lines of chemotherapy in this trial, and they were randomized to get sacituzumab or to get treatment of physician's choice chemotherapy. And the primary endpoint was progression-free survival. And what we saw was that sacituzumab was associated with a significant improvement in progression-free survival compared to standard chemotherapy, with an improvement from 4 months in the standard arm compared to 5.5 months with sacituzumab. So that was a hazard ratio of 0.66. So the delta between the two arms was 1.5 months. I think many people have felt that this difference is pretty modest. It's a month and a half difference. And is that a clinically meaningful difference? But what I would say is that I think we have to be very cognizant of what this patient population is, because again, remember, these are very heavily pretreated patients. You see the PFS in the control arm is 4 months. And so in truth, I think this is a group of patients where we need more options for therapy. And if you look at the landmark analyses here, you can see that there's clearly drop off very quickly in those first couple months of therapy where, they're very refractory patients who are coming off treatment quickly. But if you look beyond that at the patients who stay on treatment beyond that first and second restaging scan, you do see these curves really do separate. And if you look at, for example, the 9 and 12-month landmarks, you really see there are a lot more people on sacituzumab compared to physician's choice therapy. In fact, 3 times as many at the 12-month mark. And so while there is no survival benefit at this interim analysis, I think that the benefit that we're seeing, while again modest, if you look at the median difference in PFS, only a month and a half, I think it's really still an important option for our pre-treated metastatic patients where we need more options. And again, when you look at these landmark analyses, you do see that there are differences between the two curves that are substantial when you get beyond those first few months. And so I'm hoping that we will see FDA approval for this agent, because it would be very nice to have for our pre-treated patients.
Thank you for that. Talking about more options, let's dive into our third abstract here.
Well, no breast discussion would be complete without talking about DESTINY-Breast04 plenary session. So the study presented by Dr. Modi got standing ovation in the plenary. There's so much to take away from the study. But if you could briefly share your personal take-home points from the study and its impact on patients of outcome.
Yeah, no, I think this was clearly, the sort of biggest highlight of ASCO in breast cancer was seeing these data for TDXD and DESTINY-Breast04. Having seen these data, it was a trial for patients who have what we call HER2 low metastatic breast cancer. So really the way that's defined is you're not HER2 positive. You have a tumor that's not HER2 0 for IHC, but you have a little bit of HER2. So you're either 1+ or 2+ by IHC and not FISH amplified. And so again, really it's suggesting that these are patients who have the target present for T-DXd. They have some HER2 protein on their surface, even though they're not truly HER2 positive. And this trial took those patients, and it was for patients who had had 1 or 2 prior lines of chemotherapy in the metastatic setting, and randomized them to get T-DXd in a 2-to-1 manner or physician choice chemotherapy. And predominantly this trial enrolled mostly hormone receptor positive patients, but there was a small cohort of actually 58 patients who had triple negative breast cancer. And the study was designed to look at PFS in the hormone receptor positive patients, and if positive, then to look at the ITT population. Looking at outcomes in the triple negative group was really an exploratory analysis. Again, that sample size was quite small. But what we saw was that the benefit was really very dramatic. So when you look at the progression-free survival in this trial, you in fact see it is double in terms of how long it is. So about 5 months in the control arm to 10 months in the T-DXd arm. And I think very importantly, also dramatically improved overall survival, which is quite impressive at this early time point to see a survival advantage with a hazard ratio of about 0.6 in the overall population. So to me, these were clearly practice-changing data. I think it's also interesting that in the hormone receptor negative group, so the triple negative breast cancer patients, again, tiny subgroup, 58 patients, but you see the exact same trend as what you saw in the overall population and in the hormone receptor positive group, that you're doubling progression-free survival. In this case, it was going from about 3 to 8.5 months. And there's also a very dramatic difference in overall survival, 8 to 18 months. So I think it's going to bring up a lot of questions in our practice. I think these are immediately practice changing. I know many of my colleagues have already started prescribing T-DXd in HER2 low patients. But, I think the questions are, one is about testing. The idea is, again, you're only going to give it to someone who's 1+ or 2+ staining, but we also know there's a lot of issues with sort of interpathology concordance with reading HER2 low. There's a very nice paper that really showed that there's only a little over 20% concordance when a pathologist reads between HER2 0 and 1+. And that's disturbing when we're making decisions for our patients based on this IHC score. I also think sequencing is going to be a big question that comes up, but I think this is a paradigm shift in the way we even think about treating breast cancer, because now we're looking at a target and we're delivering therapy based on the target. It is not a subtype specific treatment decision. It is really just knowing if you've got a little target there, that this drug works. So I think it's going to also change the way we think about drug development, which is really exciting to see.
Absolutely. Dr. Tolaney, you brought up sequencing. Given sacituzumab and T-DXd, in a hormone positive low HER2 patient, let's say you use T-DXd, and then would you feel comfortable using another ADC thereafter? Is that how you would consider sequencing these drugs?
Yeah, it's an excellent question. Certainly, I think T-DXd is going to fall earlier because it was in DB04, for 1 to 2 prior lines of chemo, and sacituzumab and Tropics 02 was 2 to 4 prior. So I think you're exactly right. We're going to use T-DXd early. And if someone's HER2 low, if they progress, it's an interesting question to know what's the efficacy of sacituzumab going to be in a patient who's seen T-DXd, particularly because the payloads of these ADCs are both topo-1 inhibitors, right? With T-DXd, it's deruxtecan. With sacituzumab, it's an SN38 agent. So both, again, hitting topo-1, but yet they have different targets. And so it brings up this question of how do ADCs work sequentially, particularly in this case with different targets, but similar types of payload. And the truth is we have no idea. There's not much data here to answer this question. But I thought it was interesting when you looked at different setting, but if you looked at the Dato-DXd data in patients who had prior sacituzumab, and you looked at the waterfall plot with that ADC, which is targeting TROP2, but also has a topo-1 payload, you could see several patients that did have reduction in tumor measurements. I think it just shows you how little we understand about sequencing ADCs. And so, yes, I would try sacituzumab post-T-DXd, but I really want to better understand mechanisms of ADC resistance, and hopefully we'll learn more as time goes.
Dr. Tolaney, thank you so much for taking the time to discuss these practice-changing studies with us today. We hope that our community medical oncologists will get a chance to incorporate all this new data in their practices. Thank you so much again for your time.
Thank you so much for having me.